Welcome back to another series today. In this video, we're talking about the individual drugs in the indirect cholinergic agonists, because in the last video, we talked about the overview of all the drugs in the indirect cholinergic agonists. So in reviewing the indirect cholinergic agonists, we said that they inhibit what acetylcholinesterase enzyme, but they can do it by reversible and irreversibly doing it. So if they do it by reversible, they reverse it for a short time. If they do it by irreversible, they are irreversing it for a long time. It can last for days to weeks. But for the reversible, we now divided the reversible into carbamate and what non-carbamate. I'm just doing the overview for those that have not watched the last video. So make sure to go and watch the last video before you come here. In the carbamate, we say there's a carbamate enzyme here specifically, which means the drugs are derived from what carbamate or phosphoric acid for the carbamate action. So for why non-carbamate, they have a function, they have a similar function to carbamate. Not that their chemical structure is not carbamate, but it's just that the function they portray looks like what carbamate. And the last classification is organophosphate. In this one, they fall under the irreversible class. So in the irreversible class, since they fall under it, they can inhibit that acetylcholesterol for a long time. Not that we don't want acetylcholinesterase enzyme. Acetylcholinesterase enzyme is good to inhibit excess cholinergic action, but the only problem is that most times the degradation is greater than the amount of acetylcholine that is binding to the receptor. So we want the binding to be more than the degradation. You get it now? So it's very much easier. That's why we have in patients that's having personal health issues, we want to increase the acetylcholine enzyme so that that action can occur fast. So in the first one, under the carbamate, we'll be talking about some drugs. The first one we'll be talking about is our Physostigmine. So Physostigmine will be the first drug. Under Physostigmine, one you need to know. So Physostigmine is derived from Nigeria from a food product called what? Calabar beans. And we should also know that since it's Calabar beans, it's also a tertiary amide. It's also a tertiary amide. And I've always taught you that anytime you hear tertiary amide, which means they can penetrate the blood-brain barrier. So which means their side effects will include what? CNS. Their side effect will include what? CNS toxicity. So they'll produce some CNS disturbance like seizures, headache, nausea, vomiting. You get it now? So they'll produce all those CNS what side effects. Now, another thing, what is their mechanism of action? Like you also know, they can reversibly what inhibit what acetylcholinesterase enzyme, but for a short time. So what is their therapeutic use? Their therapeutic use, they are used as antidote for anticholinergic poisoning for patient that has been taking atropine, or patient that is induced with atropine. Maybe the patient has low heart rate, then they induce the patient with atropine, and when there's excess atropine, it can give you anticholinergic effect, so you can counteract it with Physostigmine. And also patient that is taking tricyclic antidepressant. Tricyclic antidepressant is an psychotic drug. So they would do the antipsychotic agent in the later will do antipsychotic agent in my subsequent video, so keep watching. So also rarely you can use a Physostigmine to manage glaucoma, because you can also use Physostigmine to manage glaucoma, but the only problem is that if you are using it to treat glaucoma, it has CNS or toxicity, so the side effect will be more than what you are even treating. Now, since we know it causes the blood-brain barrier, it can be metabolized by the liver, so the liver metabolizes it more. And also the half-life lasts for about 15 to 40 minutes. So 15 to 40 minutes, let's just say less than 1 hour, or in some textbook you can say 1 to 2 hours. So what is the side effect? Like I tell you, it has CNS toxicity, so you'll be seeing something like convulsion, you can see something like seizures, you'll be seeing something like nausea, vomiting, you'll be seeing something like various you'll be seeing various CNS side effects. Also, you see bradycardia naturally, you see hypertension because of their binding to the M2 receptor. You also see, due to their binding to the M3 receptor, you'll be seeing salivation, lacrimation, you'll be seeing sweating. All these are side effects when you use Physostigmine. So you don't give it to patients with asthma, COPD, any severe side effect like cardiovascular side effect, or patient with epilepsy, or that is have seen any form of seizure. Don't give it to the patient like that. Now the next one we're talking about is our what we call Pyridostigmine. So Pyridostigmine is just under the group of Physostigmine. They have the surfaces stigmine, so you can remember them. So the only difference that Pyridostigmine is not a tertiary amide, it's a quaternary amide. Don't forget, tertiary amine means it can penetrate the blood-brain barrier. Quaternary amine means it cannot penetrate the blood-brain barrier. So the only usefulness here is that it has what a longer duration of action, more than neostigmine and physiostigmine. One, it is different from physiostigmine that it doesn't penetrate the blood-brain barrier, and it has more longer duration of action than neostigmine and physiostigmine because it acts for a long time, by 3 to like 6 hours. It acts for a very long time, so it can be used as a first-line treatment of myasthenia gravis for its maintenance phase. So once a patient presents with myasthenia gravis and you want to treat him pharmacologically, you can use what pyridostigmine. Also, you can also use it to reverse what neuromuscular blockades, like I told you in my previous video. For patient that is treated with a neuromuscular blocker, especially during general surgery, you can reverse it majorly with neostigmine, but also you can also add what pyridostigmine. But pyridostigmine can only work for a long time, and first of all, used as a first line treatment in myasthenia gravis. For military use, it can be used as a prophylaxis against what nerve gas or poisoning. In military, they use it as prophylaxis against what nerve gas or poisoning. So here for the pharmacokinetics, it can be used given what oral, IV, or what intramuscular what route. It can be given to oral, IV, or IM, anyone, and its half-life is about 1 to 2 hours. While for physiostigmine, the half-life is about 40 to 90 minutes or below 90 minutes. Yeah. So now it can be excreted through the kidney. While for physiostigmine, it can be metabolized through the liver. Don't forget. Now, what is the side effects? It's similar. It's how you can get what muscle cramps, you can get fasciculation, you can get what increase in bronchial secretion, you can get bronchial spasm, you can get so many side effects. But that one's similar to what neostigmine. Side effect. So contraindications, you don't give it to patients with asthma, COPD, or any intestinal or urinary route because they are targeting the muscle specifically. Don't forget. The next one we'll be talking about is neostigmine. So remember pyridostigmine. Pyridostigmine and neostigmine have the same function, almost the same function. But the only difference here is that the pyridostigmine acts longer than neostigmine. That's the difference. Yeah. The difference is here. The difference is that pyridostigmine acts longer than what the only difference is that pyridostigmine act no longer than neostigmine. The same thing. They are quaternary amine like pyridostigmine. They are quaternary amine. But physostigmine is a tertiary amine. Don't forget it. The same thing, they reversibly inhibit acetylcholinesterase for a short time. Because the duration of this one is 2 to 4 hours. While the duration of pyridostigmine is 3 to 6 hours. Don't forget. So the function here is that they can be used to treat myasthenia gravis alongside with pyridostigmine. But pyridostigmine is used as a first line treatment. But you can also add neostigmine. Don't forget. Also, it is used to treat neuromuscular blockade. I also told you pyridostigmine is also used. But the only thing that when you want to start a patient, the first line treatment you can use is neostigmine to reverse neuromuscular blocking agent. Also, it is used to treat postoperative or postpartum ileus patient with damaged parasympathetic innervation. So when there is no parasympathetic innervation to the GIT tract, what will happen? You will not be moving through. Peristalsis will reduce, which means motility and secretion will also reduce. That's why you use neostigmine to tackle it. Remember, in the direct cholinergic agonist, we use betanicol for that. So in this indirect, we use neostigmine. Don't forget. So it's used as myasthenia gravis. It is used to reverse neuromuscular blockade, and it's used for post-operative or postpartum ileus, and also patient with neurogenic or patient with neurogenic bladder, or when there's prolonged urinary retention. Don't forget. Now the pharmacokinetics here, you can take it orally or parenterally. Orally or parenterally. Or another thing again, it has poor CNS side effect, which means you will not produce any CNS side effect, and it can also be excreted using the kidney. Just the same thing with pyridostigmine, and the side effect is the same thing. GIT upset due to excess peristalsis movement, and when there's GIT upset, you have abdominal cramps. When you have abdominal cramp, you have diarrhea, because when there's excess GIT motility and secretion, your food will be moving fast, and there will be less contact with time. Again, the patient will have bradycardia due to the interaction with the M2 receptor together with hypotension. Due to the interaction with M3 receptor, the patient will be having salivation, sweating, and also there will be muscle fasciculation and cramps. Same thing with pyridostigmine. Also, the contraindication, don't give it to patient with what COPD, asthma. Don't give it to also with patient with bowel obstruction. Don't give it to patient with what peptic ulcer disease. So we have talked about Physostigmine, Neostigmine, Pyridostigmine. Also, we'll talk about Rivastigmine. So Rivastigmine also is under the carbamate classification, but Rivastigmine will have the same function with Donepezil and Galantamine. So we'll be talking about them equally. We're talking about them equally. Now, under Rivastigmine, Donepezil and Galantamine, the three of them, but the only difference that Donepezil, Galantamine fall under the non-carbamate action, while Rivastigmine is under the carbamate. But three of them are what CNS selective drugs, or we can call them the Alzheimer's drugs because they tackle what Alzheimer's or what dementia. Don't forget, they tackle what Alzheimer's or dementia. What is Alzheimer's dementia? Alzheimer's dementia is a neurodegenerative disease where there's less amounts of cholinergic synapses or cholinergic neurons in the brain. And when there is a decrease in cholinergic action or due to a decrease in cholinergic neuron, what happens? There will be decrease in cognition, there will be decrease in balance movement, and so many stuff. So one thing you are, they are tertiary amine. Why? Because their action is in the brain. Just like Physostigmine, they will produce what CNS side effect, but in Rivastigmine, Donepezil and Galantamine, they are used to treat a CNS condition called what Alzheimer's dementia. Also, they can also help to treat or manage what Parkinson or disease. Parkinson what disease, especially patients that have a dementia part of Parkinson disease. So they can also use to work on that. The same thing, they are also reversible. They are reversible indirect cholinergic agonists, which is for a short time. But the only difference here is that their bioavailability is high, especially when you give the patient IV. Their bioavailability is high, and Donepezil has a long lifespan. It can last for about 70 hours. Hey, can last for about 70 hours. Rivastigmine can also just last for about 1.5 hours. So 1 hour 30 minutes can just last for 1.5 hours. Also, Galantamine can last for about 70 hours. So, and Donepezil and Galantamine can last longer, about 70 to, and the Galantamine is 7 hours. So Galantamine has more longer duration than even Pyridostigmine, while Donepezil has the highest duration of what action, and they can be degraded by what they can be metabolized by the what liver. Don't forget, they can be metabolized by the what liver. The side effect we should know, since they can penetrate the CNS, so they will give you nausea and vomiting. They also give you seizures as side effect. The patient can have insomnia. The patient can have vivid dreams, especially using the Donepezil because of its long lifespan and longer duration of action. There will also be diarrhea. There will be syncope. These are the side effects. Don't forget, due to the CNS penetration, it will have CNS side effect. Vivid dream, syncope, insomnia, bradycardia, all these things, you will find them there. The contraindication is still the same thing. Um, the contraindication is still the same thing. You also have asthma, COPD. Don't give it to patients like with all this stuff. So since we are done with it now, the next one we're talking about is the non-carbamate now. So we have talked about Galantamine and the Donepezil already together with Rivastigmine. So under the non-carbamate, we'll be talking about Edrophonium, because in this video I talk particular that we'll be talking about the carbamate and the non-carbamate. We're talking about the carbamate and the non-carbamate. So the non-carbamate here, we have the Edrophonium. So one thing you have to know, Edrophonium has the shortest duration of action. It can just act for lower than 10 minutes. The duration is very short, principally, and it is a what? A quaternary amine. It's a quaternary amine, which means it do not penetrate the CNS. It doesn't penetrate the CNS. It's just used as a diagnostic agent, finish, because it is used to diagnose what myasthenia gravis. So you just want to give it to the patient in order to what elicit a contraction. You just give it to the patient in order to elicit contraction. So we call it the tensilon test. The tensilon test is when Edrophonium is given to the patient to just elicit a brief contraction. So when you elicit a brief contraction for patients that's already having paralysis, so when you give it Edrophonium, immediately you see a brief contraction, and that brief contraction will just last for a short time. So that's when you know that okay, this patient has what myasthenia gravis. Also, it is used to differentiate between what cholinergic crisis and myasthenic crisis. So when you want to differentiate between cholinergic crisis and myasthenic crisis, you know you use what? You use Edrophonium. Also, rarely it is also used to reverse what neuromuscular what blockade. Don't forget, it's also used to reverse neuromuscular what blockade. Very, very simple. So what is the pharmacokinetics? It can be what it has a rapid onset, and its half-life is about 1 to 2 minutes, and just like others, it can be excreted from the kidney. Don't forget. So the side effect is still the same thing, the contraindication is still the same thing. So we are done with the reversible indirect cholinergic agonist. Don't forget. So I hope it all made sense to you, which we have talked about specifically the reversible cholinergic agonist. So always watch my video, continue watching my video. The next one we'll be talking about is the organophosphate. So go to organophosphate and know when there's organophosphate poisoning. So keep watching my video, continue to like, subscribe and share always. I'll see you in the next video. Bye bye.